So I'd like to welcome Aaron Samuels. Thank you very much. Yes. I'd like to welcome Aaron Samuels from the Center for Disease Control and Prevention, Kenya, Atlanta, United States. And his talk will be on antenatal clinic surveillance for malaria, whether it accurately reflects community malaria infection prevalence in high transmission setting in Western Kenya. Oh, it's come up now. So.
Great, thank you very much, everybody. I'm going to talk to you today about the potential of using pregnant women attending first ANC visits as sentinel populations for malaria surveillance. So surveillance systems are used to prevent and control adverse health outcomes in populations, and the data can be routinely used to monitor trends in disease incidence and prevalence, to inform supply chain needs, to evaluate the coverage and impact of interventions, and to direct resources and targeted interventions to reduce morbidity and mortality. And so qualities of good surveillance systems are going to be things that enable us to do this effectively. And so one of the things, obviously, that you want is a representative surveillance system that allows you to characterize the population of interest and what's happening there. You want a sensitive surveillance system that allows you and is able to pick up discrete trends in time and space. And you want a timely surveillance system, not one that you're getting information on every year or every few months, but ideally you would be getting information on a daily basis so that you can implement change to improve the health of the population. And obviously, with everything that we do, we'd like things to be relatively inexpensive. So for malaria, routine malaria surveillance in Western Kenya, we have two basic types of surveillance systems. We have passive case burden surveillance systems, and we have active infection prevalence surveillance systems. So the traditional passive detection systems that we have are outpatient facilities, and they split these up into under fives and over fives. And we also have integrated community case management where community health volunteers will visit households and test symptomatic individuals and treat them. So the advantages of these types of passive detection systems are that these are easy access groups. The people are coming to you, and therefore it's a relatively inexpensive system. And you're getting continuous data sources, right? People get sick every day. They come in, you test them, and you treat them if they're positive. And these generally give you estimates of the entire population age range. As I mentioned, you're getting kids that are less than 5. You're getting adults as well. And typically, these outpatient facilities are distributed amongst population densities. So you may be able to estimate from what's happening within a certain health facility as to what's happening in the population that surrounds there. But some disadvantages, and we learned a little bit about this, is that they underestimate the true burden of malaria infection, right? There are a lot of asymptomatic infections out there. People who are asymptomatically infected are less likely to come into a health facility and seek care. And they do not collect information on intervention coverage. So in the setting of malaria, for instance, you might want to know what is the long-lasting insecticidal net bed coverage and usage in the population. And you're not going to get that from outpatient facility data. Active infection prevalence data are really powerful in that they give you estimates of transmission, right? So it is all infections that are contributing to transmission in a certain area. So that's a big advantage of an active surveillance system. And the traditional one for Western Kenya and much of sub-Saharan Africa are these malaria indicator surveys. And these happen every 2 to 5 years, and they give you an estimate of the infection prevalence in children aged 6 months to 14 years of age. And they give you that estimate sort of on a regionally or nationally representative level, right? So they're not going down to a more local level. So the advantages, again, are that you get estimates of infection prevalence. And typically in these surveys, or pretty much always in these surveys, they're also asking questions about coverage of interventions, usage of interventions, et cetera. But the disadvantages are that these are not continuous data sources. They happen once every 2 to 5 years. They're not things that you can act on immediately, right? The data are not granular to the level of, say, a village or a health facility level. And so you can't really have targeted interventions on a local scale. They ignore the contribution of adults, and these are very expensive systems. So as I had mentioned, the case burden systems, they underestimate community infection prevalence. And a big reason for that, as I mentioned, were the asymptomatic infections in the population. And here's a nice little figure to the right there that shows on the x-axis the prevalence of infection in communities. These are 16 sites in 14 different countries, and on the y-axis is the proportion of the infections where people are not recording or reporting any symptoms at all. And so what you see is that even in the lowest transmission intensity areas, so here less than 5%, 60% or greater of the population who are infected are reporting that they don't have symptoms. So these people probably aren't going to go to the health facilities. They're probably not going to be picked up in your passive detection system. But yet they are believed to contribute significantly to malaria transmission. Why is population prevalence important as opposed to just looking at under fives? Well, we know as well that as people get older, they tend to acquire immunity and they tend to then therefore have more asymptomatic infections. So if you're just looking at under fives, for instance, you may underestimate the burden of malaria infection prevalence in a community. So getting back to the whole point of this talk, why would we consider pregnant women as a sentinel population for malaria surveillance? And like OPDs, women attending antenatal clinics, they're an easy access group, right? Women are getting pregnant every day of the year. They're coming for antenatal clinic visits. They come to you, which makes it less expensive and therefore more cost effective. As I mentioned, these visits are year-round, and maybe potentially is a difference to other outpatient department visits. Because women are coming to you not because they're sick with malaria or another disease, they're coming to you because they're pregnant, they may be more likely to come even in the setting of stockouts at health facilities because they're coming just to get a checkup. This may be a representative sample of the population. In Western Kenya, greater than 90% of women come to at least one ANC visit. And just like OPD facilities, ANC facilities tend to be distributed amongst the population, amongst sort of the density of populations. And so these may again be representative samples of the population around them. And again, these may also provide an estimate of infection prevalence as opposed to case burden, because women are getting tested at their first ANC visit irrespective of whether they have symptoms or not, right? So they're not coming because they're sick, they're coming because they're pregnant, they're getting tested. So they may be very similar to a person who's sitting in their household who gets tested at a household visit from one of these community surveys. So this correlation was explored before by Van Eek et al. In a paper in 2015 in Lancet Global Health. The authors performed a meta-analysis and they compared community infection prevalence from multiple indicator cluster surveys, malaria indicator surveys, and demographic health surveys. So they got an idea of community infection prevalence in a country, let's say, at a certain time period, and they compared that to information from the Malaria and Pregnancy Library, so the first ANC visit at the Malaria and Pregnancy Library. So they looked at community infection prevalence in kids less than 5 years old to the malaria prevalence in pregnant women. And they had a total of 57 data points, and they calculated a Pearson correlation coefficient. And for those of you who are not familiar with this, it's a test of a strength of a linear correlation between two variables, where in this setting of a positive correlation, one would be it would be the strongest correlation you could have. And anything pretty much above 0.5 or so we would consider a strong or a large correlation. In this setting, they found that malaria prevalence in women attending ANC visits was highly correlated to community infection prevalence in children less than 1 year old. And they had a Pearson correlation coefficient of 0.87, which again is quite high. And so they interpret this as meaning that these two data sets are highly correlated to one another, and that there is a potential for pregnant women to serve as a sentinel population for tracking malaria transmission. So we wanted to explore this correlation in our local setting in Kisumu, Kenya, in Western Kenya. And so we decided, though, that we wanted to do this on a smaller spatial scale. As I had mentioned before, we want to be able to make decisions in real time with continuous data, and we want to be able to make decisions at a targeted focal level. So can we extrapolate from these data what's happening in a very discrete area and intervene? So we took data we did a longitudinal register review of routine data from 9 ANC clinics in Rarieta sub-county of Siaya County from December 2015 to November 2017, and we collected information on RDT positivity, at first ANC visit, gravidity of the woman, and location of residence. And we compared this to community infection prevalence. And the way that we evaluate community infection prevalence is that in Western Kenya, we have a rolling cross-sectional survey where 5 days a week, every week of the year, we have study staff who are visiting randomly selected households to get estimates, precise estimates of malaria infection burden in discrete areas over time, so that we do get these population representative samples. And we decided, much like what was done in the manuscript that I mentioned before, to calculate Pearson correlation coefficients. So here are the data that we have at first, and this is on the x-axis you have months. So we have a total of 24 months, and on the y-axis we have a proportion. The blue line is the prevalence of malaria infection from the community as determined by CMS, and the red line is the test positivity rate at ANC clinics over time. And as you can see, you look at this, maybe you're squinting your eyes, but you can see that they sort of generally track one another, but it's not easy to tell per se just by looking at that whether these are strongly correlated or not. And so we did just as they had done in the manuscript. We created a scatter plot. We have 24 different points. Each of these points represents an infection prevalence in the community and a test positivity rate in the ANC clinic at any given month. And we calculated a Pearson correlation coefficient for this, which was 0.66 and was statistically significant. We did the same thing with the spatial correlation. So we had 9 different health facilities I mentioned. They had 9 different catchment areas. We took the data from the CMIS, from the community infection prevalence surveys in those same catchment areas. We created the same plot. We have 9 different points here. We fit a line to it and calculated a Pearson's correlation coefficient, which was 0.73, even better than the spatial correlation. And in summary, we concluded that the malaria data collected continuously from routine ANC registers were correlated to community infection prevalence in time and in space. And these are at a more granular level, both of time and space, as to what is seen in the MISs and other surveys. And while these rates from ANC surveillance were not equal to those from the community infection prevalence surveys, the strength of the correlation suggested that we would be able to track infection prevalence trends, and you could pick up seasonal trends. And in fact, there was an LLIN campaign that we were able to monitor the changes from that in the system. So this may be a low-cost option for surveillance to inform targeted interventions moving forward. And in the future, we would like to explore some other relationships in this, looking at paucigravid and multigravid women and seeing if the correlation improves when we just include paucigravid women. But we would also like to try to take advantage of this data set and start asking questions about LLIN coverage and usage when people come to the health facility, because that would help us as well to evaluate the impact of our interventions. So thank you very much for your time. I'd like to thank everybody here.
We have time for 1 or 2 questions. 1 question.
Thank you for your presentation. I had a question about the percentage of the pregnant women in the population that were using the facilities. Do you have an idea of private versus public, and number of women who are attending the facilities versus staying at home?
Yeah, that's a really good question. So in Western Kenya in general, more than 90% of women do attend ANC clinics. We just used routine data collected from these systems, so there were no additional efforts that were put into them. I believe 2 of the clinics that we utilized were private clinics, and the other 7 were public clinics. I haven't looked at the data yet to evaluate whether there were any differences, but starting in April of this year, we actually have hired staff specific to this project to really get complete data sets. As you might imagine, not all of the data are collected as well as we would like. So we hope to be able to explore some of those questions then. Thank you.
Sorry, next question.
Thanks, Aaron. Great talk. In the paper you cited, they looked at the strength of correlation at the prevalence declined or increased, and they showed actually that it wanes as you go to higher prevalence. Did you look at that relationship in your data?
Yeah, so we are just in one transmission setting in Western Kenya, and it's a high transmission setting. And one of the things, if you notice, our correlation coefficient was a little bit lower than it was in the manuscript that we quoted here. And one of the things that we wonder is, because we are in a higher transmission setting, is it possible that that's the reason that our correlation wasn't quite as high? And if we were to have a larger spectrum of transmission settings, we might see better correlation. So we weren't able to evaluate that in our data set, but we would certainly encourage other people who may be interested in this question to do the same.
Thank you very much.